Hi, we're going to start the webinar. I think you will enjoy. And as you know, it will be translated into Spanish. Okay, Spanish. And we'll talk about the adrenal hormone therapies. It's actually a presentation of a model for physicians and health professionals. But first of all, I'm happy to introduce you to Dr. Christophe de Jager, Christophe, you're there. Okay, can you unmute your tone? I think I have to.
It's done.
You. Yeah. Have you unmuted? Okay, good. And I would like to stop sharing my screen for a moment. Christophe, I'm really happy to introduce you, and to all the ones who are listening, I first have to say that we have 2,600 registrants from 96 countries. And I'm extremely happy to introduce you to Christophe de Jager, who is actually, in my opinion, probably the first physician in France to work on hormone therapies, and also he has a special approach. He's you're a geriatrician, I believe, information, and a gerontologist. So you really know a lot about aging, and you're doing also a lot of testing. We'll talk about this later. Christophe, can you just say maybe a word? Hi from France, and that you're happy to be there.
Yeah, sure. That's easy to do. I'm very happy to be here and to have the opportunity to speak with you and all the attendees of this webinar. And I hope that we share a lot of interesting things tonight. And I'd be very happy to bring my knowledge and to answer all kinds of questions the attendee could have.
We're also very honored, and it will be very interesting. I'll probably have a presentation about 50 minutes, and then I'll be interviewing you, and then we'll have question and answer session. So I think it will be extremely interesting. So I'll have to unmute you now, and can you take out your video if you can? If you take out the video, okay. Thank you, Christophe. And then I will share you my screen again. Here it is, sharing. Good. Okay, actually the topic of today is, I think, of extreme importance. We're going to talk about adrenal hormone therapies, and you will see that these therapies are critical. There's especially one with cortisol, but the second one, like Audacion and even DHEA and prenatal, are very critical in a lot of situations. And I'll try to give you this perception how important it is, and we'll start talking actually about the cortisol first. So here are the adrenal glands that make cortisol, DHEA, Audacion, and prenatal. And these hormones are major hormones to stay alive and handle stress. Nobody here would be listening if you are not producing one of cortisol. You're almost sure that you won't be alive tomorrow. So the fact that you have cortisol make you it possible to follow this lecture. And in the model that is for physicians, a real training program, we're going to talk about, in the first session, about cortisol deficiency and diagnosis, about medical history, complaints, physical science, lab tests, and things. The second will be on cortisol treatment and everything related to this type of treatment. And you'll see, I'll be talking in this model and a bit in this session without any taboos, because it's really important that you get a perception that these hormones can make the real difference in people. There's also DHEA and deficiency and diagnosis. The whole session also, they're usually about 2 hours. And then there's a session about DHEA treatment problems and its beneficial effect in disease that will be seen in a fourth session. A fifth session will be on Audacion, prenatal, and therapies and all the different aspects physicians need to know how to treat them. And there will also be a session on patient cases. And later on, we'll have in the nutritional program, that is a separate program, all the dietary, nutritional, and lifestyle therapies that can help increase cortisol and DHEA levels. And let's look at what's available in cortisol deficiency session, the first session. In this session, there will be information about personal and familial medical histories that point to a deficiency. So people can have already since very long untreated cortisol deficiency, and it can be in the family. Actual complaints that are specific for cortisol deficiency have to be collected by a physician to make a diagnosis. And then there's a very important physical exam where there's no hesitation. You really can see the difference. And then there's low cortisol levels that can be associated with a lot of different diseases. And I'll just very superficially overview that in this overview session. Lab test, also how to make diagnosis. When is a lab test really showing a deficiency or not? This will be interviewed. Now, for those who are interested and like some free information, I wrote an article in the Townsend Letter, which is probably America's #1 alternative journal that really gives very practical information to physicians how to work with human molecules or natural molecules. I wrote a big article on cortisol, and it really resumes the importance of cortisol, that cortisol deficiency is frequent, life impairing. It really makes a mess of your life if you don't have enough cortisol. And it explains how to give the patients their lives back by correcting it. And it's so much information that has been spread over two of the journals, the January 2018 and February and March 2018. And it's available on the internet. So you can find it up and you have a lot of information, even though in the model that I'm talking about, there's even much more information and much more details. And now the importance of cortisol is evident. And I already told you that a total disappearance of cortisol is dead within 24 hours. But that's not the case a health professional will have to treat. Most cases will mainly be cases of people having a partial deficiency in cortisol. And that's also makes of life something not so easy to tackle with. So that is in a sort of Addison crisis where there's a crash of the blood pressure and a crash of the blood sugar levels. You cannot survive it when it's too severe. And now to show when there's a deficiency, it causes distress. Stress should be pleasant, actually. Stress is a challenge. Everything that happens to us in our life should be a challenge, a spiritual challenge or a psychological challenge or a physical challenge. But anyway, a challenge that is okay. But if you experience as too much, you probably are cortisol deficient, because it causes then the impression that stress is too much as distress. And that's a miserable life. So people are always complaining their life is not good. They might be deficient in cortisol. And to just show you what happens with cortisol, you have a sort of maximum of all the hormones around 18, 25 years of age. But then the cortisol metabolites, those are, when cortisol is used as a hormone, it becomes a metabolite. It changes its structure. And that gives a good idea of the activity of cortisol in the body. And it drops about 25% around age 70 compared to before. So that's enough to give a lot of stressful feelings. But there's another problem, is that the anabolic hormones, the hormones that build our body up, the hormones that keep our body young, actually decrease much more. And so there's cortisol is a catabolic hormone that actually consumes tissue to give you energy. And that's right, if there's enough anabolic hormones. And that's not the case when you are aging. So if you correct cortisol deficiency, you almost always have to correct at the same time other deficiencies in anabolic hormones to have a right balance. Very, very important. And so now with aging, there's something more that happens. With aging, hormones work on receptors in cells, and it's in the nucleus of cells that the cortisol receptors are. And they decline with aging. In the brain, it has been shown, brain hemispheres has less receptors. In the hippocampus, also part of the brain where the memory process happen, like here. The skeletal muscles, there's a lack of glucocorticoid receptors, and also in the liver, and in the kidneys, in all the important organs, and probably in the heart and the blood vessels, etc. And this gives that with aging, there is, when you look at all these older people, even if they have normal lab tests with cortisol, at least the blood test, for example, there's a peripheral resistance to glucocorticoids because there's not enough receptors for the cortisol. And so with aging, the blood and urine cortisol levels become more and more misleading. Even if you have a lot, there's maybe not enough receptors for those hormones to work. And so the clinical examination, the physical exam, remains very important. And just to give you an idea of, there are a lot of factors that can accelerate the deficiency or cause a transient deficiency, and that people are actually following. And one of those is the birth control pills we're giving to all of those young women. And that's a cause of low cortisol, this pill. And for example, and when you look at this study, oral contraceptives, 4 different ones, they all were increasing a protein in the blood that transports cortisol throughout the blood. And when this protein is in high amount, 3 times more when there's on the average with these oral contraceptives, actually keeps more of the cortisol in blood and less goes in the cells. So that creates a cortisol deficiency with high cortisol levels in blood and low in the target cells. So that's not a happy phenomenon. And physicians and health professionals have to take that into account. Sometimes it might be advisable to stop the pill, but there are other things we can do. We can correct the cortisol deficiency in women who have this problem with the pill. And actually, I'm sad to say, but most of the young women do have a problem of cortisol when they're taking at least a high dose pill. Now, how do you make a diagnosis of cortisol deficiency? Well, diagnosis can already start very early in some echographies or pictures. Here, for example, this is a fetus in utero. And when you look at the fetus, you see there are dark circles under the eyes. There's probably behind that conjunctivitis, inflammation of the conjunctiva, typical for cortisol deficiency in adults. Hollow face, not a very fat fetus or rather hollow face. And there's thinness also, and irregular pigmentation. You have the impression of irregular pigmentation here. So also in utero, they can be cortisol deficiency. So we'll look that over in the model and have an idea what to do. And it's usually the pregnant mother that has to be well treated. And her food, for example, is detrimental and very important for the cortisol production of the baby. Thin child, eczema, or allergies and asthma in childhood must make you think that there is cortisol deficiency behind it. And how do you treat that in children? There will be some information given about that. And so now, when we look at what cortisol does, it really hurts people. People suffer much more with cortisol deficiency. If you have too much cortisol, you're in euphoria. You're too happy and you don't care about people. Even if somebody's dying, you don't understand why that person is complaining, because you feel great, at least in the beginning when you have too much cortisol. But if you have too little, anything that happens becomes a drama. So they really suffer more. It's not fake, it is real. They feel more suffer. They're inflamed. The brain is inflamed, literally. And that creates also this psycho-emotional suffering. There's so characters that have been depicted in statues, like here you see the suffering of this person. That was certainly a cortisol deficient person. You see the hollow cheeks. And probably if we had seen the person in real, we would probably have seen other signs of cortisol deficiency. You see they will have a low resistance to stress. Even if the stress is not so severe, they suffer much more. So are you, as a doctor or as a patient, do you really want that this cortisol deficiency persists because you suffer needlessly? It's needless suffering. It's elevated by correcting the deficiency. And then you see there's also feel overwhelmed by work and stress. And typically they will say any work, any stress is actually too much of them. They become burned out. This is the main deficiency behind burnout. You won't be able to recover from a burnout sufficiently if it's a severe burnout, if you don't correct the cortisol deficiency. I think I can say that based on my experience. And typically also in cortisol deficiency, there are adrenal outbursts. Among the most common psychological fears is they quarrel all the time. You say, for example, if your partner has a cortisol deficiency and you say, for example, I love you, you would imagine that this person would be happy. But if that person is really cortisol depleted, they will be distressed. They will say, are you sure you're really, what do you want from me? Are you trying to handle me so that you get some advantage? And so they are even a lot paranoid. And then they quarrel easy because of that. They interpret reality as more bothersome than it really is. And how do they look? Well, typically a cortisol deficient patient has hollow cheeks. And you see this more brownish tint and more brown here around the dark circles of the eyes. And they are also thinner because the intestines are inflamed, and the intestines are inflamed, do not absorb well. There can be some anorexia also, and lack of appetite that makes they don't eat enough. But even if they eat enough, they may not absorb well. Hollow cheeks, hyperpigmentation. Here also you have more brownish tint, but you also have pigment spots, dark circles here more, and irregular brown pigment spots. And why does this happen actually? Well, it happens because when you're cortisol deficient, the pituitary gland in the brain secretes ACTH, which is a hormone that stimulates the secretion of cortisol by the adrenal glands. And if that hormone is too much secreted, you get more pigmentation everywhere. And in a state of cortisol deficiency, it is also as pigment spots. And those pigment spots are irregular, like you see here. They're not just like irregular, they're not H spots, they're actually Addison spots from Addison's disease, from the lack of cortisol and the excess of ACTH. And then I will give in the model a lot of information about the impact of cortisol deficiency on disease. In a lot of different situations, low levels correlated with more disease. And I'll give you two hints. For example, people who have too much appetite at night, they have to eat in the middle of the night, get hungry. It's because they have hypoglycemia. And that is linked actually in this night eating syndrome to an attenuated ACTH, an attenuated cortisol. So they don't make enough cortisol, and then their blood sugar drops. And they need to eat mostly cookies or sweet things to correct their deficiency. And that's easily corrected by having a little cortisol before evening. They need anyway the cortisol for many other reasons. And then a cortisol deficiency in Alzheimer's diseases seems to be associated. The lower the cortisol is, the more severity there is dementia by atherosclerosis in this case. It is really, you also see that quite violent reactions from people with Alzheimer, and they look like very mistrustful and paranoid, but that's typical the cortisol deficiency behind it that does it. And then there are laboratory tests and blood, saliva, 24-hour urine. So I'll discuss that in the model. And I won't discuss it here, but I do discuss also intimate degrees of deficiency. So people who have laboratory tests of cortisol within reference range, but are deficient because they have a lot of complaints and those levels are linked to disease. In session 2, we'll talk about cortisol treatment and we'll overview lifestyle, dietary, and hormone therapies that increase cortisol. We'll have also glucocorticoid supplementation, physical improvement with glucocorticoid therapies. I will show pictures before and after so that you really, as a physician, can print in what you need to know that what change happens with the treatment. There will be also cortisol overdose. There will be physical signs and symptoms and how to overcome cortisol treatments. And then we'll also see how treatments correct disease and how efficient they are. And then we'll also talk about the hormone imbalances that can be caused by treatment or by deficiency of cortisol that is left untreated and how to repair that, how to correct that, because that's really interesting. And I, without any hesitation, I can say that in multiple hormone therapies that are given now for optimization of health or for reduction of aging, if many cases of patients come with intolerance, and that intolerance can be due to cortisol deficiency and has to be well corrected. So it's really a gift for a physician to be able to treat correctly with cortisol, and that for that DHEA is necessary and other things. So I will explain that in details in this lecture, and how also COVID is probably the post-COVID syndrome of the post-COVID vaccine syndrome. People who remain sick or tired after the vaccine or after COVID disease, well, they usually have developed adrenal deficiency. So by correcting, being able to correct adrenal deficiency, you can help these patients out and get them their life back. That's really what cortisol does. It gives people their life back. They're not in survival mode anymore. They can really live fully their life again. Now, to correct cortisol deficiency, you see there's light is one of the tips. If you increase light, you can increase cortisol and also cortisol receptors. So here, for example, this study, when you put individuals, healthy men who have had some sleep deprivation, 1.5 days they haven't slept, and their cortisol levels are usually very depleted. But if you put them in bright morning light, it's the morning light, this light, what happens is that it increased by about 50%. There's an increase of cortisol in within minutes, or it's almost an immediate process. And the melatonin that calms you down, that also calms cortisol down, goes down and then decreased by about 6 times. And if these healthy men were submitted to afternoon bright light, it didn't have the same efficacy. No effect on either hormones. Meditation also helps to have better cortisol levels. Here's a study that showed you that people who regularly meditate, they are able to have, during meditation, lower cortisol levels, but outside of meditation, have high levels. So when they need for energy, they have more cortisol, but they don't spill it when they're meditating. So really, and there are other influences that does it. And then there are hormone influences that change cortisol levels. This is the cortisol molecule. The red atoms are the carbon atoms, the blue ones are the hydrogen. And so it's based on the structure of cholesterol. So if you don't eat enough cholesterol, you probably won't have enough cortisol. So pregnenolone can help it a bit, IGF-1, insulin can help it, testosterone can increase the levels of cortisol. And thymosin alpha-1, we'll discuss that in details with studies and things. Thyroid can increase or decrease. We'll discuss it in the model, how it does and what's the conditions so you can discriminate. DHEA will rather have an adverse effect. If you give an adrenal hormone, it will decrease ACTH that stimulates all the adrenal cortex hormones. And then there will be a drop of the other adrenal cortex hormone, including cortisol, when DHEA is given. Aldosterone, fludrocortisone is the same. Growth too. Growth can have a very strong inhibitory effect on cortisol. You have to be careful with growth hormone. Melatonin, also oxytocin, and estrogen, especially oral estrogen, decrease cortisol. So it gives you a good idea of what happens. And this is just an overview slide. There's much more details given in the model. Now, there's a treatment, and I add always DHEA and other anabolic hormones when you give cortisol. I never give cortisol. I have with me a little bottle with cortisol, fludrocortisone, that's aldosterone, and DHEA. And each time I have a need to have an extra dose, I take at least two of the three of them. Now, this is hydrocortisone can be given, and so those are a synthetic derivative, prednisolone or methylprednisolone. I always prefer, in general, to give the bioidentical one, but there are certain conditions where it's safer to give a synthetic derivative and more efficient. So cortisol is mostly necessary when there's hydrocortisone is the same as cortisol, it's the bioidentical one. That improves energy more in tired persons. So if the person is tired and has low cortisol, you give cortisol, you're almost sure that the fatigue will be much better. Prednisolone is more given when there's to decrease inflammation. It's more efficient because it has a 24-hour action. And methylprednisolone, when you have inflammation, but also supplementary, there's a problem of hypertension, or edema, obesity. Because methylprednisolone is not water retaining. So if you given those conditions, patients do better with it. How to adjust in stress and disease is abundantly discussed. I won't go in details here. I have to make some selection. And then the glucocorticoid treatment on hormone balances is also well discussed. And then we arrive at DHEA. DHEA is with cortisol, the most produced hormone in our body in milligrams per day. And we'll see here also personal and familial medical histories suggesting DHEA deficiency in the person or in the family. DHEA supplementation, the physical exam with physical signs that actually show deficiency. Here it should be a slide with complaints of DHEA deficiency. It's a little error there. And the diseases associated with low cortisol levels, and then the lab test, serum, saliva, and 24-hour urine test. So we'll discuss that. Just to mention, for those who are in the French-speaking country, I wrote a letter that explains in details DHEA, and also wrote in French a book, DHEA, the hormone of better life, a long time ago when DHEA was not so well known, and it is still now very actual because I'm very detailed in my information. And now let's look at how much DHEA is there in the blood. And when you look at young women aged 18-25, you see all sorts of hormones are in the blood, but DHEA is all over on the form of DHEA sulfate. The S is a sulfate. And DHEA is the most abundant hormone in the blood. It's after cortisol, the most produced one in milligrams per day in our body. And you see that there's 12 times more DHEA than IGF-1, which is hormone number 2 in blood, and then 35 times more than cortisol, and 30,000 times more in the blood than T4. So it remains in blood much longer than any other hormone. It's also produced in high amounts. And in older women, they have atheroma plaques and they have less hormones. Cortisol is slightly less, DHEA sulfate is less, T4, IGF-1, there's much less testosterone and estradiol and growth hormone. And that means also that DHEA sulfate still remains relatively abundant, but it's much less. It can decrease up to 10 times at a lower level in older adults. So 5 to 10 times lower levels than a younger woman here. So let's look at the complaints of DHEA deficiency. When you look at a person who has DHEA deficiency, those complaints are not so clear-cut as for cortisol deficiency or thyroid deficiency or female hormone deficiency. But the person will say, I feel a little anxious, my mood is rather low, I feel some tiredness, my libido is low, and my erections are poor, for example, if a patient is a man. And so it's moderate complaints, moderate low quality of life complaints. And there's also several studies associating depression with low serum DHEA sulfate levels. And what happens is when the depression declines, even if no supplementation you give DHEA, usually DHEA levels go up. So the higher DHEA sulfate levels are, the better it is to have a good mood. And this has also been shown in adolescents, not only just in all adults or older adults. So there's really a progressive increase of serum DHEA levels. Also for erectile function, low levels are associated to more erectile dysfunction. And here a study in Korean men who were complaining of low erections, and they had significantly lower DHEA sulfate levels than in other men of the same age who did not have erectile dysfunction. And what about the physical signs of DHEA deficiency? Well, there's a puberty onset androgen deficiency. DHEA deficiency is already there at puberty. And what happens is that the pubic area will not develop fully. It will remain confined, a small pubic hair area. This Tanner stage 3 is underdeveloped, and that can point on a DHEA deficiency. DHEA, more even than testosterone, is the important hormone behind it. And at puberty, for example, the first sign of puberty is hair on the pubic area and in the armpits. And that's the only hormone that increases at that moment is DHEA sulfate in blood. When it starts in adults, there's a different situation. There's a full-grown pubic area with hair, like here, but there's a diffuse hair loss. And so that's typical for adult onset androgen deficiency. The scarce losing of hair. And what about DHEA deficiency and disease? Well, there's many studies on that. There are a lot of studies on cardiovascular disease showing that low DHEA sulfate levels in blood are linked, for example, to more stenosis, of the coronary arteries. So here you have the coronary arteries. There's 1 stenosis, 2 stenosis, 3 stenosis. And you see that the blood levels, if you have 1 stenosis, is 18%, then 25% for 2 stenosis, and 34% decrease of DHEA sulfate levels with 3 stenosis in men, middle-aged men. So if you want to keep your heart in good condition and the coronary arteries of your heart, it is better to have enough DHEA sulfate. And in rheumatoid arthritis, for example, in men, there's a significant lower levels of DHEA sulfate, 55% lower DHEA sulfate levels. And that's not a unique phenomenon. And also patients with rheumatoid arthritis have an increased incidence compared to others of abnormally low DHEA sulfate levels. Women with rheumatoid arthritis, it's worse. Women actually often feel the effect of DHEA deficiency much more than men. 83% decrease in serum DHEA sulfate levels. And so the situation in rheumatoid arthritis in women is worse. They need more DHEA than men. And what about living long? Well, living long, you see that there are levels of DHEA sulfate in old adults that are linked to lower mortality. But what is very clear-cut, if you're really in a very low level as a woman and you're disabled, DHEA sulfate, the lowest level lowest quartile of level, you have at that much more mortality. You see, this is the survival curve, and when it's low, means that there's a lot of mortality and there's not much survival. And in older men over age 65, a group here of 260 older men were followed during 2 years, and those who died actually had 61% lower DHEA sulfate levels. And when you look at the reference range of young men, you actually see that these levels are below the lower reference range of young men. But older adults, the DHEA sulfate levels collapse in older adults. So their references is much lower. And those patients are within reference range of very old people above age 65. And older men who died after 4 years, compared to men who stayed alive, had a 27% lower serum DHEA sulfate. And this suggests that keeping a good DHEA sulfate levels would be much better for these men to live longer. And there are many studies now out there. I have at least found 10 studies that show that link with longevity with DHEA. Now, there are laboratory tests to see their blood, saliva, 24-hour urine. And when we look, this is, for example, the lower limit of DHEA sulfate levels of young men. And this is the upper limit. Well, if men have a DHEA sulfate levels that is below the 700, so that's below the lower reference range of young men, but it is within the reference range of older adults, older men, there's more mortality in men with chronic heart failure. And below the 1,000, there's dyslipidemia. There's also more fat mass and less lean mass. There's also more cardiovascular mortality, 3 times more if the men have a DHEA sulfate level below 1,450. So they die easier from cardiovascular disease and also from overall mortality, 50% more. And then there are the inverse associations showing that, for example, there's more metabolic syndrome. So the lower the levels of DHEA sulfate are, the more you have all these diseases like aggressive prostate cancer. If you have HIV, your RNA levels are higher. If you have diabetes, you have glycosyl hemoglobin is higher. And that means that the higher you are, the better it is for health. So these regions, and that is part of that, are within the reference range, are actually a range where you don't have optimal health. And to have optimal health, you should be high normal when you study all these studies. And I made a specialty of looking at all these studies because it really justifies the urgent need for people to get the right treatment. Then there's session 4 on DHEA treatment. And basically we'll see methods how to boost DHEA activity and what are the problems of DHEA therapy and what are the visual effects in disease. So very practical as always. Just give a look on interventions that increase DHEA levels and activity with self-supplementation. And I'll pick one, a habit that we get. We want to save the planet and we want to eat healthy. And then we know, soy is good. I buy it in the health food store, so it should be good. But it is not so good because when you do soy feeding and you take the amount of 12 ounces, which is 340 grams, 3 times a day during a month, that decreases the DHEA sulfate levels by 14 to 30%. And it also decreased the sex hormones, the female hormones, the male hormones. So it is not ideal, I can tell you from experience, for your sex hormones to take a lot of soy milk. If you take it twice a month, but don't take it 3 times a week. What about DHEA treatment? Well, sometimes with DHEA treatment, you can get an overdose. So how do you treat it? And one of the overdose can be in women that they get facial hair. This is an exaggerated picture, but some facial hair can happen, and a facial hair stays 4 years on the skin. So imagine the distress. Of course, you can take it away, and if you change the balance, it won't come back. So there are many methods. And we'll discuss actually in the model how good you can treat that, and how can you also avoid the problem. And what you have to do with DHEA treatment, if it was given, do you have to stop for a while or not? We'll discuss all these conditions. Very practical. And let's look at what DHEA supplementation can do for disease. Well, I don't have any slides here, but it's very interesting. Sometimes I have to take some animal studies, like for cancer and for reversal of atherosclerosis with DHEA, but many studies are also done with DHEA supplementation. And so let's look at here, for example, DHEA treatment improves the quality of life in women with adrenal deficiency. This is a woman with adrenal deficiency. You see the hollow cheeks, the brownish color, the dark circles on the eyes, and she probably put some makeup that hides the pigment spots. And so this is a meta-analysis of 10 randomized controlled trials. It did show that there's some improvement in health quality of life. I remind you that I said that DHEA deficiency symptoms are moderate, so you have a moderate improvement also of things, but you do have a significant improvement, and there's also a small beneficial effect of DHL depression. So the effects are smaller than with other hormones, but you have to consider DHEA as a fantastic protector against cortisol side effects. So it has a very important function, is to protect us against adverse effects of cortisol, so that we don't have to worry about cortisol in our body. It also improves sexuality in women. Here, women with adrenal deficiency, for example, who receive a high dose, 50 milligrams high dose for women during 4 months. It doubled the degree of sexual interest. So many here who have a woman who may not have so much libido, well, might have to correct the DHEA deficiency in their wife. And almost doubling of mental satisfaction with sexuality, almost doubling of physical satisfaction with sexuality with that, and also more than doubled the sexual thoughts of fantasies. And actually, it took time to do that. It takes 3-4 months sometimes to get good results, except for sexual thoughts or fantasies that already after a month were significantly improved. And what about the dyslipidemia? Well, we'll look at into details, but when you look at an artery and you take blood, the DHEA can decrease the total LDL cholesterol in women, increase the HDL cholesterol, the good cholesterol, also in women. They can decrease the dangerous cholesterol, this is oxidized LDL cholesterol, the triglycerides, and we'll see that based on studies, and the lipoprotein A, 10 to 20% in the women. And you see, I didn't put men because here's an exception. DHEA is not so efficient for in men to improve lipids. It doesn't have adverse effects, but it's not so efficient. And so DHEA supplementation has many other effects also on the blood sugar levels. For example, these are adrenal deficient women, and they receive the DHEA treatment at high amounts, 50 milligrams. I don't suggest you to take as a woman at 50 milligrams, but 20 milligrams. But at 50 milligrams, it has efficacy to decrease the serum total cholesterol, LDL cholesterol, the triglycerides, the serum HDL cholesterol, and the serum HDL cholesterol. There's some decrease here. So this corrects a little bit the information I previously said. In this studies, not all studies show a lowering of HDL with DHEA, but it remind you it's 50 milligrams. But the overall effect is better. And lipoprotein by 18%. And there are many cardiologists who say you cannot do anything for lipoprotein. Yes, you can. Correct DHEA deficiency. And what are the effects of hormone treatments on DHEA is also seen, and it's really interesting because to know this hormone balance that is really critical. Now let's look at the 5th session, Audacion and Adrenal Hormone Therapies. We'll look at all the aspects physicians need to know about the dose, how to solve problems, what are overdose signs, what are deficiency signs, etc. And let's look at aldosterone therapy. Aldosterone, there's an age-related decline in secretion and that they undergo. And we see here, for example, that we'll look over actual complaints, physical demands, diet problems, lab tests, and nutritional supplements. That's part of the nutritional program that will be separately seen. And then fetal cortisol supplementation, and it's the overdose that you can have and other practical details. Now let's look at the aging I was talking there. And you see that young adults, age 30 to 40, have actually good levels, let's say optimal levels or adequate levels of aldosterone in the urines. But in older adults, it decreased by 50%, but not in a normal test. You have to, in order to see the difference, is you have to go on a salt-free diet. Salt-free diet, the body has to react by keeping the water in the body, by keeping then the salt to keep the water in the body. And aldosterone is salt-retaining hormone. So if you don't have enough aldosterone, you won't be able to keep the water in the body. And that's one of the reasons why older adults are dehydrated. The wrinkles are sharp, the eyes are deep in the orbits, and they need to drink more water. So what happens, what does aldosterone really do? What is the important? Well, aldosterone is there to keep the water in the body and to keep the blood pressure high enough. So if you don't have enough, you don't feel good there. But if you have enough, you see clearly, you focus well with your eyes, you can pay easily attention, you feel good in your head. Especially when you sit up and you stand up. You sit or stand up, this is really the position that where you need enough aldosterone. Not if it's just for a minute or two, but if for half an hour or hours on a row, yes. So really that helps a lot of people feel good when they sit for prolonged time or they have to stand for prolonged times. So this is the aldosterone deficiency look, you see. The person is here, but it's not there. It's absent-minded look, foggy look. That's typical. When you see this, you can ask a question to your person who's there in front of you and you ask, did you, etc. And then the person seems to wake up. Well, that person was staring at you and asked, what did you say? What did you ask? That's typical for aldosterone deficiency. Also, this foggy, drowsy posture. So if you have that, get on treatment, do your lab test, check your symptoms, and go on treatment. So sometimes aldosterone is one of the adrenal hormones that is missing. So there are a lot of adrenal hormones, either sex hormone missing because it's all the same family. Then you can have this thin, lean face and body silhouette. That's not just due to aldosterone deficiency, due to the other deficiencies in similar hormones. Also, when you don't have enough aldosterone, you cannot keep the water in the body. So you have to go to the bathroom very quickly. You drink water, woof, you need to go to the bathroom. So they're urgent and frequent needs to go to the toilet. And also aldosterone is the hearing hormone, the number one hearing hormone. If you don't hear well with aging, need to go on aldosterone. Severe hearing loss occurs then. People with severe hearing loss have 50% lower aldosterone levels. There are a lot of receptors in the inner ear for aldosterone. And aldosterone really helps to get hearing back. Laboratory test, blood, 24-hour urine, we'll see that in details. We'll talk about also the products and the doses and how to do the follow-up. And one of the things you should be aware if you're a health professional giving aldosterone is that there doesn't come swollen feet. That's the first sign of excess. Swollen hands too. And that's in the end of the evening or the end of the afternoon. It's not in the first part of the day. It's really when you've been standing and sitting for prolonged times, you get swollen feet. And it's a pitting edema because it's really due to water retention. And that's usually when there's too much aldosterone. We'll talk about how to solve that also. And then our last subject now will be prenatal therapy. And that's the we'll see actual complaints, physical exams, physical signs, lab tests, prenatal supplementation, and then also the effect of prenatal on disease. And what is prenatal? Such a long name, you would say. Well, prenatal is a major precursor for glucocorticoids, for mineral corticoids, and for androgens. And because of androgens can convert to estrogens, also for estrogens. So it's done when cholesterol is converted to hormones, it's first past the phase of prenatal. And then it goes, prenatal is differentiated to other types of hormones. So all these major hormones are produced from prenatal. And prenatal is abundant. You find it in the brain, for example, in frontal cortex here, high levels here, in temporal cortex, high levels, in parietal cortex, also high levels. And when you look inside in the inner section, the amygdala, the high levels too, the hypothalamus, that is there to stimulate the pituitary gland to work better, and the hippocampus, also high levels. And look at the blood levels. Blood levels, much lower levels. On average, 20 to 40 times lower levels in blood of prenatal. So you have much more in the brain and than in the blood. So it's really important for the brain to work well. And how does it, to give an example, in animals, like in mice, for example, mice, you can make them have a bad memory, having amnesia, by injecting in them a substance, a DMSO. And to restore the memory back, you need relatively high amounts of testosterone. You need about 5 times a lower dose of DHEA. So DHEA is more efficient to improve the memory than testosterone. But prenatal, you need 500 times a lower dose to restore the memory. Imagine that. That shows you how potent it is. And this is really much more efficient for, in my experience, mostly short-term memory. And here you have patients with schizophrenia, and they received in a double-blind placebo-controlled studies 50 milligrams of prenatal. And it really improved their deficits in visual attention, in visual and sustained attention, and it improved the executive function. So these schizophrenic patients were more able to do work. And also spatial working memory was better. Those who received placebo had no improvement. So it really makes a difference to give, and you need 50 milligrams per day during 8 weeks to get that sort of improvement. It's a slow treatment. It doesn't work in 2 or 3 weeks. You need more time. In my experience, at least 2 months, if not 3 or 4, to get results. And here's the thing, but there are many other things that I will tell in the model, but I'll give you one of the tips. Take prenatal in the morning. Don't take it in the evening. You don't need to have a good memory at night, but you need to have good memory during the day, so take it in the morning. Now, prenatal and attention deficit disorders, you see these boys that are aged 7 to 15 years, and in these boys, the lower the serum pregnenolone was, the more they had these symptoms of attention deficit hyperactivity disorders. And there's really an inverse association. So lower levels of pregnenolone, more attention deficit hyperactivity disorders. And this may suggest that this treatment might be good for attention deficit disorder. And I find in my experience, it really improves these boys and girls that have that problem. And it's safe. It's really a safe hormone. We'll see a lot of other situations. Let's look at some laboratory tests. Here again, you need blood and 24-hour urine. We'll talk specifically about tests in the model. And here you see, we'll talk also about the doses that have to take, where it's sufficient, where not, and what are the problems you can have, etc. And we'll also have a special session 6 on patient cases with cortisol, DHEA, fluorocortisone, and prenatal treatments. Of course, we'll discuss about the diagnosis, how we make the diagnosis, really practical information, exactly the information that physicians really want to know. And so I've arrived here at the end of this lecture. We'll have then the talking with Dr. Jager, but before that, I want to give you a little overview of the evidence-based hormone therapy postgraduate program I made that I think really is really adapted to the needs of physicians who want to learn about hormone therapy. You can really go on this link. You just bring your mobile phone nearby, and you can then really get all the other information. But in the first cycle, there we've seen an extensive model on infectious immunity and inflammation, inflammatory disorders, reversing physical aging, and everything is really updated with the latest news. But what is even more important is practical information, how to do it, how to do female hormone supplementation. And generally, most of the models are made of 4 sessions of 2 hours. Some are longer, some are shorter, but on the average, that's what you have. And then this is really a must for anybody, also for nutritionists, chronic fatigue and burnout, because we'll talk also extensively on nutrients in that. Thyroid diagnosis and treatment, melatonin diagnosis and deficiency diagnosis and treatment, and testosterone in men, testosterone in women. Very extensive information, like probably not have it nowhere, but also not boring. I mean, it's really exactly the information you need to have. And the first 5 modules, there are Spanish subtitles, so that also for people who mostly have Spanish as mother language, it will be really helpful. And I really thank the physician who works for that, and that all that great work. And cycle 2, the one I'm working on, is the hormone therapy consultation, adrenal hormones, that will be in a week online. The growth hormone IGF-1 therapies, that will be next month. And psychological disorders and hormone treatments, extending longevity. You will be absolutely fascinated by those 2. I think everything's fascinating because I'm a fascinated person. I mean, I'm passionate about what I do, but I think the information is exciting because it really helps you to see clearly and have new tools for your office. Then cardio and cerebrovascular diseases, very rich information, hopeful for cardiologists, but also for any physician who has to deal with these diseases. Sexuality, very exciting, I would say, practical, but we're still very respectful, so don't be afraid. We don't lose the borders. And then there's obesity, also management. So really the information that most physicians really want to have and can do really very good things. You can also contact this email to get information. Our next events will be, you can also register. You close your iPhone. December 14th, we have the question and answer session, which are for the postgraduate students. That's next week on a Wednesday. February 1st, 2022, there will be a free overview webinar like this on growth hormone and IGF-1 supplementations. And February 8th, 2020, there will be the Bionurso webinar online event with Mexico. So that's the dates. Good. I will now stop sharing my screen, and I will ask Dr. Jager to start his yes, and the video is good, and the audio is also on. Okay, good. Christophe, I'm really honored actually to have you, because I think you've done also very fundamental work in France to diagnose aging and diagnose memory problems. Can you talk shortly about exactly how you do it in France and what you do exactly?
Okay, we have two different situations. You can have some hormonal deficiency in younger people, let's say 40, 50, maybe 60, with memory impairment. And you have, on the other hand people over 70, 80 who have also memory impairment, but they are starting a real brain disease. And you may know that everything is not just Alzheimer. You have actually 72 pathologies who can show up by memory impairment, and Alzheimer's disease is one of them. So you have to look at everything, and first, before getting in this kind of how do you say
program, I think, diagnostic program, probably, no?
Diagnostic program, exactly. You have to be sure that you have a problem of memory, because it's very subjective. You have a lot of people who think they have not a good memory, and really it's not so bad, and the inverse is also true. So they have to have tests. And we're working on, so I have a lab where they can go through tests and we can see what kind of memory is impaired. When we have this first diagnosis, then, of course, for example, there's one pathology who is quite usual, who is depression. Depression can give you some memory impairment. Most of the hormonal deficiency can give you memory impairment. So you really have to have this first diagnosis, and then you can go to try and find the cause.
Are you treating then with hormones to correct the memory problems, or do you have first another approach before you provide hormones?
Yeah, my second approach is a neurophysiological approach. So we working on EEG with cartography, so we can see the brain electrical spectrum, and in face of the temporary lobes, for example, also the frontal. Well, anyway, we're studying the frontal on the two sides, parietal, temporal, and occipital lobe, and we're working on evoked potential. And for example, there is one who is very much linked to pregnenolone, and this one is the P300, or cognitive evoked potential. And they are very much allongé, how do you say that?
Lengthened, longer or lengthened?
Longer, thank you, very much longer. And if you give pregnenolone, for example, then in a 6 months time range, well, it improves.
So you really see changes in electroencephalogram, the EEG, that's electroencephalogram with pregnenolone.
Sure, we do. And that's very exciting. So, of course, it hasn't to be a big diagnosis like some vascular dementia or things like that. It has to be on a brain who is still quite healthy, but who is just dysfunctioning. But
do you have also other effects of other hormones on your encephalogram? Do, for example, testosterone or growth hormone also improve the encephalogram?
I have I have not such kind of results with testosterone, and I don't use growth hormone, so I can't tell you about that. But so we have a first test who is about memory tests. We have then everything who is about neurophysiological, and of course we ask then IRM, magnetic field exam, to
IRM,
see exactly
magnetic resonance imaging, MRI.
Right. MRI, right. And now then we have very precise imaging about neurological degeneration or vascular pathologies. So when the three are done, we can have a first impression of the diagnosis. And then I love to go to all kind of hormone screening. But I would say personally, then, for example, estrogen are very interesting in brain functioning. But it's quite difficult to put on a treatment with people who are over 70, because then the medical community may be quite
Opposite.
There's no problem with pregnenolone, they don't know it. So they say, okay,
Yeah.
I don't know what that is. It's
What about
Hertoghe.
DHEA in France?
DHEA is helpful also, but you know, pregnenolone is transforming DHEA. So I always start with pregnenolone, and I see about 3 months, 6 months, if we have a transformation. Most of the time, on aging people, we don't, because the enzymatic system doesn't work so good. So then we have to go with a DHEA complementation.
And do you work then also, I think you work with female hormones and testosterone for just health optimization, for improving the health, or not so much in France?
No, that is my geriatrics field. Now, of course, I'm working in health optimization. I would rather say it's about senescence. So it's quite different, because people are not coming and see me to say, okay, I have a pathology or I don't feel good. They come and see me to have a real physiological cartography. And so we're studying everything. They have a whole day checkup with blood and urine analysis. And then we can see exactly how they're aging. And whatever their age is, they can. It was also an interesting study, observation, because at the start, when I started 40 years ago, a little bit like you, we're quite the same generation, and we are both started anti-aging in Europe. But at the start, my population, the population I studied, was marked by the fact that I was a geriatrician. So it was an older population. And slowly, but very regularly, this population is becoming always younger. And most of my population today is between 50 and 60. And the youngest is 26. And the more age is 95. And
Oldest, yeah.
you couldn't imagine what he's doing. He said, I'm 95 and I'm in best shape, a lot better shape than I was in 65.
Wow.
And you can see it. He's walking. You know, there's in clinic, there's something which is very interesting. It's the way people are walking. How is it changing their direction?
So you analyze the way they walk, and then you can see the difference. I mean, if they have to be treated or the effect of the treatment on the walking.
Yes, and it's something very general. In fact, it's very long consultation, because you have to feel the real feeling of the people. You have to notice that. Then you have the physiological tests who are telling you if there's an improvement or not. For example, in the bone mass, in the muscle mass, are they changing or not? The arterial rigidity, your evoked potential, and then there's the blood test. And we're making a mixed up of everything to always be more precise in the quality of the advice we give to this patient.
And then you do follow-up, I suppose, and you do again
Sure.
the testing to see if it improves.
Yeah,
and do you see, for example, do you do a Doppler test of the carotid arteries to see the atherosclerosis? And did you see some reversal with the treatments or not?
It's something who is major, Thierry, because if you hear cardiologists, they say there's no way of reversing. If you look at that, as we do, we see if everything is fine and optimized, you can have a reversal. We can see stenosis of maybe 60% of one carotid, and 1 year after it's 50, 35, and then it always stays a little bit around 10, but it never goes to 0, to 0. But it's a real success when you see that.
Wow. So that's, and then of course they must be quite passionate to see the improvement. Now let's talk a bit about cortisol. I think you work also with hydrocortisone. To which patients do you give it, actually, hydrocortisone, the cortisol treatment?
Well, we make a checkup, and if we see that they have some deficiency, we correct it. Most of the time, they also have a prenatal deficiency, and we start with as a prenatal correction, and then we see that the cortisol is going higher. And so that is the first step, I would say, for us. Sometimes this is not sufficient, and then we have to start with small dosage of hydrocortisol, very slowly, very carefully. It's sometimes difficult because you have some sugar in the blood, it's limit. And if you go too far with hydrocortisone, then you could have problem of sugar regulation. So it's a real job. But we
provide always DHEA with hydrocortisone, or you?
Yeah, sure.
Yeah,
sure.
Okay, so they are always protected this way. So that's interesting. Can you remind a case of a patient who really improved a lot with just hydrocortisone when you provide the hydrocortisone that really made the difference?
Just hydrocortisone?
Yeah, well, sometimes you're treating your patients, you may be giving the sex hormones, and there's still something wrong, it doesn't improve. And then when finally they go on hydrocortisone treatment with DHEA, they're much better. Have you had some of those patients?
Yeah, sometimes. I never start everything at the same time. I always go very cautiously and test everything. And sometimes you don't have the improvement we should have. And then, of course, you're looking at the cortisol level and you see, well, this cortisol level seems good, but something is lacking. And then you try to introduce hydrocortisone, and it's very fast relief for the patient. That is something.
Yeah, it works quickly. Yeah, that's true.
Yeah, very quickly. It's really interesting, and you find also real diseases, real cortisol deficiencies. I'm very surprised about that because there's so much people who feel tired, upset, not good, who are going from doctor to doctor trying to find a solution. And even in the hospital, they stay a few days and nobody has solution. And then with a little bit of cortisol, their lives really change. And that is really interesting. And they love that, of course, because it's really before and after.
Well, that's great. I think we're having quite a lot of questions, and so I would like you to participate. And we'll also, after the questions, we'll show your book. I think you have written your latest book has been published, and we'll show it to the public because Dr. Jager has written a lot of books in French, but they're very good. So I would almost say, why not learn French and then you can read the books. So here's a question. We'll see what a woman can do if she has cortisol deficiency and she wants to get pregnant. Thanks. Do you want to answer? Otherwise, I'll answer.
Please answer.
Is that, well, when a woman has a pregnancy and she's cortisol deficient, she will have a lot of vomiting. She will have also easier miscarriages if she's not treated. So giving hydrocortisone during pregnancy is completely authorized. Of course, the doses are not enormous. In a woman, it's 20 milligrams for an average woman. And if a woman is very small, it's 15 milligrams. If she's bigger, it might be more. But there's always a little DHEA has to be given. And DHEA has the, in pregnancy, DHEA is through the placenta is much more converted to female hormones. Actually, 1/8 to 1/7 of all the female hormones come from DHEA in the pregnancy. There's a sort of change in secretion. So you can do it. The doses are generally 10 milligrams in the morning, 10 milligrams at lunch for hydrocortisone. And DHEA, then I do give a little bit less, like 10 to 50 milligrams, not more. Usually I give 20 milligrams DHEA for 20 milligrams hydrocortisone to get the right balance. Then another question, what about bloating, gas, and constipation? I think constipation, that is maybe thyroid deficiency if due to, and bloating gas is usually a wrong food intake. So a good food, many people bloat and gas because they just eat proteins in the evening. So then I will see, I have a lot of questions on cortisol. Maybe a question that you could maybe answer is, hello, for a person who has adrenal insufficiency, what food supplement can we provide? Do you have an idea, or do you want me to answer this?
Please do. Please do.
Okay, when there's adrenal deficiency, you should go look at the model on nutritional therapy and adrenal hormones. But you should first avoid some foods. Avoid absolutely sweets and sugar 5 days on 7 per week. Because that decreases the cortisol level up to 20-30% even. The good food for improving cortisol, DHEA, etc., is protein intake, and specifically fat intake, animal fat, like cholesterol, like butter, like egg yolk, like ghee, and things like that. You often see, then here I come back, another technical question. You often see abnormal low ACTH with low cortisol. Yes, if a person has an adrenal deficiency, but it's due that the pituitary gland doesn't work well, ACTH is low. And there's a big difference with Addison's disease. Addison's disease is the adrenal glands don't work well, and the brain works well and makes too much ACTH in compensation. But when there's low ACTH, the person never gets brown or pigment spots. The person is rather too pale and burns in the sun. And that can be due to a lack of, the pituitary gland doesn't work well. So I have tested low for both, but have Cushing's type symptom along with anticella. Well, this will be too technical, I think, to answer it here. And there's a lot of different possibilities, but I will try to get the questions that most people can answer here. Maybe this is interesting for you, Dr. Christophe. Is the psycho-emotional suffering leading to a deep and permanent depression to our patient? Does all the antidepressants lead to a proper recovery, or should we focus on hormone therapy? Do you think, what is better for depression? Antidepressants or hormone therapy?
Well,
especially when it's a lot of suffering.
Yes, I would say the main answer in global medicine is to give antidepressant. But if you do that, you're losing a chance to really deeply help the people. Because if you have, for example, testosterone deficiency or other androgen deficiency, you can really go in deep depression. And when you correct it, then life of people change. So really, if you see something who is depressed, well, you have to ask the question, how are their hormones? And it's sometimes difficult because people say, well, I'm depressed, I need an antidepressant. So you have to explain it. And then they're very happy because they got another solution, because the whole life is becoming more bright.
Yes, I completely agree with you. Hormone therapy works usually much better. You have to note that I started to specialize as a psychiatrist, and I saw so many hormone deficiencies. These people, I thought that something's wrong with psychiatry. They're giving products that decrease hormones that aggravate the problem. And so basically, I had much more success by giving thyroid therapy, by giving testosterone therapy, female hormones. Those are, let's say, the three best actually for depression, but there are many others. So good. What is the quality of the data of these studies? I don't know which studies. There's no in. Oh yeah, it's Eric Bravemont. I love you. But aging, cortisol can go up and DHEA and prenatal can drop, but aren't there so many clinical factors? So we don't need blood oils yearly to adjust. So we extend health span. So Eric Bravemont is a famous physician in the United States that works a lot also on the brain. You probably know him because of Jager, and he's online. And basically, he has the typical American position, and we're afraid of cortisol. And but fortunately, in the United States, there was a Dr. William Jeffries who was working as an assistant in the team who got the Nobel Prize for cortisol discovery. And so he wrote a book on safe use of cortisol, and that is good. The thing is that that book has to be added. You have to take with cortisol always DHEA and other anabolic hormones to have a good balance. And then it's safe. And you shouldn't be afraid to age quicker with cortisol. You will age less. I have enough experience now to know that there's a way of making hydrocortisone safe. And most of my conference, when I start with talking on cortisol, it's safe cortisol therapy. And that's really possible. If you would give DHEA and prenatal after age 30 or 40 years, in my experience, does not convert enough to cortisol. So you cannot correct cortisol by giving prenatal. And DHEA lowers cortisol. There are 13% to 25% lowering of cortisol when you give DHEA. So you would aggravate the problem. It's only to people with too much cortisol that you can give DHEA to lower it. Can high DHEA level cause hair loss? Do you want to answer that question? Can high DHEA...
Yeah, but before I can understand that a lot of people are afraid of cortisol because with the other what we call cortisol, prednisolone, etc. Well, if you give that
cortisol is prednisolone. It's a synthetic derivative that's bought in France.
If you give that on long time, you can have a lot of side effects. And those side effects, well, they are very much in the memory of people and practitioners, and they just want to avoid those side effects. But if you use hydrocortisone, well, it's totally different. It's absolutely not the same biodisponibility. It doesn't stay as much in the blood. So it's a totally different story. Now, and of course, you have to give some DHEA and other hormone to keep the balance with the anabolic hormones. So it's not so easy, and you have to make the right tests. So the thing is, it's always a little bit complicated. Thierry is making that for 40 years. I do it also. But when you start that, it's complicated. So really, you have to be helped, I think.
You have to be cautious and not to high dose. And you always have to balance with other hormones and also with the food. For example, if a person is on a grain diet or a sugar diet or a high carb diet, you get side effects with cortisol even on low doses. So you really have to do a sort of complete change in your food, in your habits. You have to have light. Hydrocortisone doesn't work if you're not in the light. So if it's too dark in your room, there are many things that we take, but when you do it, it's safer. And as you say, you're completely right, Christophe. Hydrocortisone doesn't stay so long in your blood. And so it's much safer than something that stays 24 hours on a time. But still, even those synthetic derivatives, you're able not to have a thinning of the skin or lower bone density if you give enough anabolic hormones in compensation. Then can high-level DHEA cause hair loss? It surely can in women, not in men. And so sometimes women are so sensitive that even if we have to give a very low dose, like 5 milligrams or 8 milligrams. So, and here's
I would say, if it appears a hair loss, you have to measure the DHT. Because the DHEA can transform into testosterone and testosterone into DHT, and DHT is quite bad, of course, for your...
So DHT, for the listeners, is dihydrotestosterone. Testosterone converts to dihydrotestosterone, and dihydrotestosterone gives masculinization, body hair growth, but can also make you lose scalp hair if it's too much. And you're completely right. You should check that. What we do, we check another test is androstenediol gluconide. That is the major metabolite of dihydrotestosterone. So you really know if there's a lot of dihydrotestosterone working. And we always try to balance. So we rarely have hair loss with DHEA or any other androgen in women, because we always keep the androstenediol on a safe level, and sometimes we give to women finasteride, which is synthetic progesterone that lowers the conversion of testosterone to dihydro. Okay, when we start, here's a question. It's in French, but I'll read it in English for the public. Is when the treatment is started with DHEA, must we take all the adrenal hormones together? I'm a pharmacist, and I remark that many patients who are treated with DHEA alone have other problems of low blood pressure, of dermatologic pathologies, I suppose eczema or psoriasis or something like that, or inflammation. What is your experience that can you give DHEA alone, or must you always give cortisol and fludrocortisone and pregnenolone, for example?
Well, I never start everything together. I always start a fall, and I start on the higher level. I see if it's transformed itself correctly. Then I always, in a second time, I will give, for example, DHEA. In the third time, I will give something else. I'm always trying to see how the people reacting. What
so you start with pregnenolone, and then if it doesn't work enough, DHEA, and then if it doesn't work enough, cortisol. Is it more or less?
Yeah, right. Okay. Yeah, more or less. And then it depends on the feeling of the people, what is improving or not. And so I always try to start with low dose, see how it's working, how people feel. So I'm very cautious.
Okay. I think it's a completely justified method. We use another method here. Most of my patients are very international patients, and they are very, they require a lot. They want direct effect. They don't want to wait. And in that case, what seems to work well, and it's even safer, is to treat all deficiencies together. Of course, we have a certain reputation, so we don't have to convince people for that. They already come for that. But in my experience, I find it helps more to treat all deficiencies. I know that in France, it's a special situation, like in many countries, where it's better that you do progressive things, and I think it's completely justified. Maybe that's also interesting for people to know. There are many physicians attending here this webinar, and many in their countries, they don't know if they can or not do hormone therapy. What is your strategy to avoid problems and to be able to treat? Do you use the healthcare system or not for the testing? How do you work? Very briefly, it doesn't have to be long.
I'm not using the healthcare system because there's two situations. People are coming and see me for senescence problem, not for disease. So if I find a disease in the whole global cartography I'm doing, then I send it back to the healthcare system. sending back with a letter saying, my dear confrere, my dear friend, I just find this and this in your patient, please take care for him. And then I follow personally the patient. But on the other side, senescence is not a disease. We know that it is the primary disease, but it's not the vision of the healthcare system. So then it's just a problem of doing things well, making the right examination, making the right dosage, having right files, where you can find, if the file is needed for some complaints, you can explain why you did that, what you expected, and what are your real results. And you have to show each time that you take all precaution before giving anything. So that is the best way.
So your advice to physicians would be this type of treatment you do outside of the healthcare system. That's the best way to work with, I would say, without anxiety, without any pressure, and then you can do your work well, because this is not considered by official system as health optimization is not considered as a disease treatment. So that's good advice. Thank you. Also, you have to know that Dr. Jager, as I have been all medical board members. I was a revolutionary. I wanted to reform medical boards, so I made a lot of fuss. But Dr. Jager was, let's say, more diplomatic and more strategic. But so he has, as me, we have a good idea of what medical boards need for you to justify treatment. And that is exactly what Christophe said, is you need to have a good medical record, do the work well, you have to justify diagnosis and have to done. And with that, you're very safe to work, and then work outside for treatments that are not reimbursable by the healthcare system. Don't try to get reimbursed. That's one of the best things you can do. Okay, are those supplementations suppressing the pituitary adrenal endogenous axis? In case, will it recover after stopping the treatment? Maybe I can answer that. Is that all the treatments that Christophe and me provide are treatments that suppress the adrenal, the function of the gland about 20–30%, not more. But you have to note that these glands, when they are deficient, are working maximum. They are wearing and tearing, they're destroying themselves by overworking. And when you give a supplement, finally, there's a relief for the gland and it works well, much better. So you don't have to expect any definite suppression when you stop the treatment. 3 to 6 weeks later, it works, the patient recovers the same system. It has been shown even for thyroid therapy, for example. The thyroid therapy, you stop a treatment since 20–25 years. There's studies on that showing that the person has the same lab test than that person had 20 years before, about 3 to 6 weeks after, which is surprising because normally in 20–30 years time, there's 10 to 20% decline of the thyroid hormones. So it spares. There's also studies in animals that have shown positive effects. There's a different, when you give an overdose of cortisol with those synthetic derivatives that Christophe talked about, is you can have a suppression that can continue 9 months until the gland finally recovers in people who had for rheumatoid arthritis overdose of cortisol without any DHEA. But we have a treatment for, in that case, you can inject ACTH injections twice a week in depot form, in a long-acting form, and then you recover in 3 to 6 weeks time, you can recover adrenal gland function. So it's quite safe to give these treatments. You don't harm when there's a deficiency by giving the treatment. Do you have maybe another experience, or do you have the same experience?
No, it's the same thing. It's the same thing.
And then an anonymous attendee says, Audacion supplement is available in the US. It was and is in some pharmacies, very expensive. That's pure Audacion and not fludrocortisone. And it works well for recovering hearing loss. The thing is that it doesn't, I tried it and it really gave me a sort of, I had the impression of having a sort of spiritual experience. I was so clear in my mind, but it didn't last long. It's too quickly metabolized. So the real aldosterone is short-lived. That's the problem. Should a low normal aldosterone blood level be treated, especially if the patient has tinnitus? Yes, tinnitus is those buzzing sounds in the ear. And what you hear as buzzing sound is the sound that you cannot hear outside. So you have a hearing loss when you have tinnitus. And if there's a low aldosterone, if you give aldosterone, it can repair the hearing loss, but also the tinnitus. We had patients putting drops in the ears of aldosterone, pure aldosterone. There's a very good firm that does that. I think International Anti-Aging Systems, and you put the drops and they hear better, and the tinnitus also goes away or decreases. I'm interested in empty cellular impact on hormones discussed today. Empty cellular impact, the cella turcica is the bone where the pituitary gland relies. And if that is empty, most of those people are having a lack of the hormones that stimulate the other adrenal glands. So you have a polyhormone deficiency. But the treatment is not to give the hormones of the pituitary gland except growth hormone, but it's to give the adrenal hormones and the sex hormones and the thyroid hormones that are low. Swollen feet can also be a symptom of cardiac and renal insufficiency. Yes. How to know the difference between probably hormone deficiency and those things. In a hormone deficiency, you have other signs of deficiency. For example, if you have swollen feet because of too much aldosterone, the person has also high blood pressure. So there are many other things. They also send to retain fluid. So they have difficulties to go to the toilet because they're retaining too much fluid. So there are many other symptoms that can make a difference. So you need to know what are the complaints of deficiency. Hi, doctor. I've been taking hydrocortisone 4 milligrams twice a day for the last 3 years because of bullying at work. Together with DHEA, I'm 44 years old. Is it safe to take them for years? Would it be a natural way to stop or reduce? So 4 milligrams twice a day for 3 years, do you think it's harmful or not, Christophe?
4 milligrams of hydrocortisone?
Twice a day, it's not much. Yeah.
Twice a day, it's very, very low dose.
And the patient takes it together with DHEA. Now, the patient also says something interesting. Patient is bullied at work. Who gets bullied at work? An oxytocin deficient person, in my appearance. So when you have a lot of oxytocin, that's a hormone of warm-heartedness, what happens is when somebody says, hey, you have a big nose and you have big feet, then the person with a lot of oxytocin likes that. Older persons, very sociable, say, oh, yes, and I have big ears, and you have a big tongue, and you have a big breast, and and everybody laughs. But when you don't have oxytocin, that's a problem, big problem. When somebody says you have big nose and big ears, they say, why does that person be so unfriendly? Why against me? That's not just. And then you see it on their face that the person is angry. And then, of course, there's a bullying process going on. So if you're bullied at work, it's often because you're lacking oxytocin and you're not turning into laugh the critics that you think you're receiving. And so I think it's worth also to get out of the bullying by having a bit of oxytocin. I know it's not so simple that bullying at work can be due to other things, but it's something that really can help to react better. I have a patient, 30 years old woman that has a high level of testosterone. No matter what she does in the nutritional part, nothing happens. She can't lose weight. The endocrinologist said there's nothing to do. What should be the advice to help her? Not sure I understand the question, but basically it's a person with high testosterone who wants to lose weight. And that's probably polycystic ovarian syndrome. And the endocrinologist doesn't say that there's a thing to do, but basically if a person needs to lose weight, there's one fundamental thing, and I think in my experience, and you probably have some other experience, Christophe, is we are not made to eat 3 meals a day. In the prehistoric times, they ate one meal a day and then a little bit snacks like fruits, etc. But they were never food found in the ashes of the prehistoric fires. There were never bones found, so never eat proteins in the evening. They went hunting in the morning, catch the prey, ate it right away because they had no fridge. Otherwise, it would be full of flies. And then they didn't eat much more. So people who eat 3 meals a day will always have a problem of weight. And maybe they have a problem of weight because they have not too much testosterone, but a lack of thyroid hormones or lack of growth hormone. So you might have to look at other deficiencies. And the typical endocrinologist is an expert in diabetes. Is not really an expert in growth hormone deficiency or in thyroid deficiency. They usually give T4, which doesn't work so well. So I think other things can be done here, other treatments, but also stop eating proteins in the evening, for example. That always gives them protein overload. Do you have any other advice you would give to a person who cannot lose weight?
Yeah, first thing, I totally agree with you. We're eating too much calories. That is for sure. The second thing is how to improve, for example, the basic metabolism. You can do it using thyroid hormones, but you can also do it in increasing your muscle mass. And though if you do so, it's another way of losing weight, because then you're not eating so much calories, you're making more muscles. Those muscles are increasing your metabolism.
So you advise physical exercise.
Right.
To get better muscle.
Against resistance, you have to make muscles. It's not just running around the building, it's making muscles. It's quite difficult.
Yeah. Okay, good remark. Here's, do you know whether there's a chance of having cortisol substitution in form of cortisol patches, such as used for Audacion? That means cortisol transdermal. There's a physician in Belgium that works with transdermal cortisol. She puts it on her buttocks, but it's a cream and it seems to work well. She has a special formula because otherwise it doesn't absorb. And she says there's no thinning of the skin there if you do it on the right way, always a thin layer enlarged. But I haven't tried it myself, but that's a possibility that can be done, but it has to be compounded by a pharmacist. Can you explain the difference between cycle 1 and cycle 2 of your online program, and which one is separated for what level of prior knowledge? The cycle 1, well, basically cycle 1 and cycle 2 of the formation are both advisable. You can also just get some training programs separately, like the one hormone consultation. If you do only one training, that's the one you should do. It's 8 different sessions. It has everything on the hormones. Of course, it doesn't have all the details, but it really helps you to work well. And from there, you can build on the program. If you do the whole cycle 1 and do whole cycle 2, you'll get much more information, and you will see it's quite unique. But basically, the cycle 1 is the one that we suggest to start, because we're in the COVID period and there's a lot of information on COVID, and there's a lot of very important training programs like the testosterone, the female, the melatonin, the thyroid hormone therapy. So you should start with cycle 1 if you want to do the whole cycles, and cycle 2 is a further improvement of it. So, but if you just do one model first, then try to do the first model of the cycle 2. How do we get pre and post comorbid data on effects of multi-hormone placement? That's from Eric Bravemont. I have made an article on the cancer risk of multiple hormone therapy and was quite positive, and have published it. I can always send it if you want to have it. Then a question in Spanish. What about using methylprednisolone? If you use it, how long? Usually when I give a synthetic derivative, I propose to take it during 6 months, because we need methylprednisolone is given when there's hypertension, for example, or obesity. And usually in 6 months' time is enough to get the hypertension corrected, or the obesity and the overweight. And then I go to hydrocortisone. That's the normal strategy. Sometimes I have to do it longer, but usually it's when I started, it's usually for 6 months. I have just been officially diagnosed with Addison's disease, which I knew it was going to be positive. I have no cortisol or aldosterone, but you still have, otherwise you wouldn't be alive, but you have very low levels. I have all symptoms of aldosterone being absent, zero testosterone. My pituitary gland is non-functioning. Okay. All issues for pituitary gland have been RO treated. I am on 3.5 milligrams of bidental estradiol. This is a woman with 2.5 milligrams of testosterone, probably that's probably transdermal. I take 2.5 milligram pills of conventional hydrocortisone, but that's too low. One at lunch and 100 milligrams of progesterone, one pill at night. I have a few questions, but I don't have any questions here. So maybe it's later that she is put. But anyway, this person is taking multiple hormone replacement therapy, but actually 2.5 milligram pills of hydrocortisone twice a day is much lower than 5 milligrams. It should be much more. When do you recommend the AM/PM cortisol test? I didn't talk about the cortisol test in the afternoon, but if you do it, it's around 4 o'clock actually. You can do a second test, and then the levels, the reference range is 2.5 times lower. So you have to have other reference range to evaluate them. If you do only blood tests, you have to do twice the cortisol test in the morning and then in the afternoon. But I do a 24-hour urine test, so I often don't do the afternoon test. Any contraindication for COVID vaccine with regard to morbus Addison, Sheehan syndrome, autoimmune disease, Hashimoto dysbiose, and Candida albicans? Okay, I'm not the best person to ask for the vaccine because I got a stroke with the vaccine. I got heart decompensation, and I had, I'm very, very strong normally, but not with the vaccine. I had the Moderna. And so I had also microthrombosis in the lungs, and I had developed during a whole time, 7-8 months, chronic fatigue syndrome with it. I still have it, but very little compared to before, and I cannot run marathons anymore. But for the rest, I feel fine actually because I stopped. But so for the COVID vaccine, I think Addison's disease that is untreated is a contraindication because it causes such an inflammation that it will be more destructive. And I personally think that you should be very careful if you don't feel good. If you're tired, that's not the moment to do a vaccine. We have a whole program at our office for people to take the vaccine so you lessen the problems. I learned a lot by my case. I tried it because I thought it was my duty as a physician to try the vaccine. And but after 4 days I couldn't talk. I got they had a stroke in the cerebellum, so that explained the problem of pronunciation. So I'm trying to pronounce very well here, so you don't see. And I don't have any consequence except the fatigue and the poor condition, and maybe it made me about 5 to 10 years older. So all these conditions, Sheehan syndrome is like an empty cella turcica, autoimmune disease. I think you should be very careful. You should treat any adrenal deficiency before. You should take high dose of vitamin D, and that's a treatment not many people have, but IGF-1 treatment is the treatment that seems to get people out of the post-COVID syndrome of post-vaccine syndrome. So you must be able to have good hormone levels. And another thing, eat well. If you don't eat well, you have more COVID, severe people go in emergency room of actually, usually people don't eat well. Do you have any advice to give for the COVID-19 vaccine?
Well, the first thing I'd like to say is in the population I'm following for optimization, we had no problem about the COVID infections. And we discovered, because we're doing blood tests each 6 months, we had the surprise to discover some people in the start of the pandemic who had antibodies and who never had any symptoms. The hardest symptoms were a little bit of fever, 38, not more, maximum 3 days. But most of the people didn't get anything. It was a real surprise for them to see that they had antibodies and that they had a contact. Now, to come back to the last question, to the previous question, of course, if you have an Addison disease or any real deficiency, you have to optimize your level before taking anything. That is for sure. Now, for example, most of the people in France get vaccine because they need the pass, the sanitary pass, not because they have they are afraid of the COVID-19, but they want to keep their freedom and be able to go, and for that to into restaurants or to go to the any bar or anything spectacle, things like that. And they need a pass, and you can get the pass just if you have 2 injections. So now most of my people who are very international people too, who need to take the plane, they need to have the pass. So they had all injection, and I had no problem about injections.
Good. It seems that the problem I have, because I made some investigation, happens in young people. They overreact by a too strong immune system. And because they checked all my arteries were fine. Even a 20-year-old would like to have no atheroma, never were. We checked everywhere. There were my heart, no heart attack. The white matter that is normally full of dirt, I would say, was completely perfect in the brain. So basically, it's probably due to an overreaction, and this happens in young military men. Also get that they seem to react too strong. So, but it's difficult. Difficult for me to tell exactly.
Also, excuse me, Thierry. It's maybe also because you had a Moderna. The Moderna vaccine is stronger than the Pfizer.
Yeah. It's like 5 times more material in it than the Pfizer. Yeah.
So it may be that also.
Yeah. So here's a person who gives a question. When I take hydrocortisone, I have more energy, but my facial expression sometimes become blunted, flat effect, meaning that she doesn't express, or he doesn't express warm feelings. I'm a warm and social person. Why would this happen? Do you have an idea? I personally, it looks like in this person, the cortisol decreased the oxytocin. And oxytocin is the hormone of warm-heartedness. We know that if you take serotonin, for example, 5-HTP is precursor of serotonin, or serotonin, an antidepressant that increases serotonin levels, that they also lose emotions. Those antidepressants work by making you more neutral, but you don't want to be neutral in this life. You want to be full of emotions, and they take the emotions away. But if you add oxytocin, it's corrected. So maybe you need to have oxytocin, and that person is borderline low in oxytocin and then collapses when hydrocortisone is taken. Dr. Hertoghe, thank you for the webinar. What is your view on treating hypocortisolism not via glucocorticoids, but via T3, triiodothyronine, also known as circadian T3 method, assuming, of course, that the adrenals are healthy and the problem is with the axis? What about, okay, there's first this question. So the patient says, why don't you take thyroid deficiency when you're low in cortisol, because it can improve, and do it with T3. Now, you have to know that with T3, you need to give T3 6 times a day to have adequate levels. So not many people are ready to take it 6 times a day because they have to put their mobile phone, and they have each time to be a wake-up call for that. And then when the adrenals are too low, there's an intolerance to T3. So they get very quickly heartbeats, tachycardia. So it's only in people who are slightly low in adrenal hormones and very low in thyroid hormones that thyroid therapy could be helpful. Then there's, what about GHRP, growth hormone releasing peptide 6, which seems to boost growth hormone, NSATH, and cortisol. The growth hormone releasing peptides do not work sufficiently well. After 6 weeks, there's a die-off of the effect. So it's not a regular treatment for long-term use. You can do it for 6 weeks, have good effects, and then the effects die off. How and where to start the history and workup for a postmenopausal female with newly released high triglycerides, LDL, edema, facial hirsutism, weight gain, and several other symptoms mentioned today. So here we have a woman in the postmenopause with a lot of typical problems like high lipids and swelling, facial hirsutism. Well, this patient certainly is lacking thyroid hormones, lacking probably cortisol, then they make more adrenal hormones that give you hirsutism, hair growth. And so you should know a whole panel, but certainly thyroid therapy, female hormone in this woman at low doses if she's overweight. And certainly some cortisol, but on the first 6 months with methylprednisolone, like 4 milligrams or 2 milligrams, maybe only. And that would be a good treatment. Oh, here's probably a problem you might also have in France that your patients may say, my current doctor, okay, we're 2 more questions then. They say how we have to stop. My current doctor will not check my cortisol levels. I have hydrocortisone and suspect I have always been deficient. I am now experiencing with hydrocortisone replacement. What signs could I look for when trying hydrocortisone that would suggest I'm deficient? So basically, do you check lab tests once a patient is on cortisol therapy? I don't check lab tests because it doesn't work. It's either too high or too low. If they just took hydrocortisone just before, there's a too high level of cortisol with the treatment. And if they don't take it, there's a little suppression of 20-30%, so the levels are lower. So you cannot really check in the follow-up by blood tests. So I understand that the patient is not followed by this test. But the question, what signs could I look for when trying hydrocortisone that would suggest I'm deficient? If the dose is not enough, what are the signs you would you suggest to look for?
I would personally, anyway, I use the urine test, and it's a 24 hours urine test. It's very good to follow up the hypocortisone.
In my experience, often the problem is that cortisol doesn't bind to transcortin long enough, and you get more cortisol loss in urines when you take an oral treatment, because it's part of that gets lost in urine. But you have it depends on the dose you give. How much are you giving actually in general to your female patients or male patients?
Not much. In the average, it would be 20 to 25 in two times, at morning and at noon. But and then it depends on how they feel. If they feel with energy enough, that would be the urine test give me some information.
Yeah. Among the tests are tests that you're, for example, low resistant to stress, you're tired when there's stress, you are getting tachycardia easy, and you're getting also your hands get sweating by an adrenaline reaction. When you don't have enough cortisol, make more adrenaline. You get armpits sweating and things like that. That can be symptoms of low. Now, I must congratulate you, Christophe, because in a certain sense, you're right for the urines, because the way I detected I was not taking enough cortisol was by a 24-hour urine test. I had taken 15 or 20 milligrams of hydrocortisone, and I had low adrenal hormones. Well, I'm sure I was taking it during the 24-hour urine test I was doing. So basically, it did show up for me, but for other patients, sometimes they have sort of loss in urines. But it made the decision that I went from 20 to 30 milligrams for me. Okay, we're going to have then one more question that's a bit long there. What about the cholesterol? Yeah, here's a question maybe interesting. It's in French, but I'll translate it in English. anti-aging medicine doesn't base itself alone on hormone therapy. Can it associate vitamins, trace elements, polyphenols, nutrition?
Question for me.
Yes, you can answer it. Yes.
Anti-aging medicine is based on a lot of things. It's, of course, nutrition, physical activities, and everything who is going down in your body. Hormones are one of them. So the thing is that you have so much things to correct that the real problem today is to find people who are sufficiently motivated to do things correctly. They have to be motivated in the anti-aging process to do the exam, to come back, to agree on tests, to take what you tell them to take, to make the life changing. And that is the problem. A lot of people, I wouldn't say most, but a lot of people think they just have to take 2 or 3 hormones to feel as they were at 20. No, it's a lot more complicated, a lot more difficult. We can have great results, but I would say the thing who is the most challenging is the real motivation of the people.
So what you say is that in most treatment, there's hormones, nutrition, food, and everything has to be combined. So it's a whole job, but it's really work because then it worked. But if you don't do that, it doesn't work well. That's basically what you said. And I agree with that.
Not so good.
Okay, that's good. Maybe I can stop here with Joel Virgilio, who says, even with Addison, I still look 20 years younger than most of my age of 54. And says, woman, I want my health back, not just to survive. I have a huge goal of starting up an autism therapy center, etc., using a very special breed of horse. I must get my health restored. So it's a patient who has Addison's disease, but apparently is not well treated. I should be candid, that is the amazing mirror. She wants to amazingly improve because Addison's disease is a terrible disease when it's severe because your life is impaired. You don't have a life, you survive. You have to do an effort for everything. Well, it should be easy. And so the good news is that this person needs probably hydrocortisone, fludrocortisone, DHEA and prenatal and all the adrenal hormones, not just one, not just cortisol. And that will probably help this person very well in the right doses. Now, just it's important to say is that you don't get your life back with a synthetic derivative of cortisol because synthetic derivatives don't work on psychological benefits so well. They work on physical, like inflammation, while hydrocortisone works more on physical improvement. So, and in psychological improvement. So if you want to reverse psychosis, there are people who have very severe brain disease can be reversed by hydrocortisone if it's due to cortisol deficiency, but you give a synthetic derivative, you cannot reverse it. There are several anecdotal reports about that go show in that direction. Okay, well, I thank everybody. We're going to have some more, some information, and I will show the book of Christophe. I'll have to share my screen again. So let me see how I do that. I think you have to, let me see, share my screen. Yeah, here. Yeah, you have to get out of, yes. Okay, I think it's this one. Share. Okay, that's the book of Dr. Jager, Aging Well Without Medication. And below is the keys of longevity and good health. So you see that he has a very good look on what to do. And you have met now with Christophe. I'm really happy, Christophe. I really thank you for being here. You've done it greatly, and I love your answers. Now, we also have books. This is the book really that helps most of physicians do well their job. Testosterone is really everything you ever dreamed of knowing about testosterone, including how to reverse prostate hypertrophy, give testosterone in prostate cancer patients and things like that, with all the data, the studies and things, all the details. It's really a very rich book. Then Reversing Physical Aging. This is a textbook on how to reverse aging with all details of the face, the hair, and the senses, even the taste. Very helpful in all those people that had the COVID and don't get their taste back. In the Atlas of Endocrinology for Hormone Therapy, new edition with a lot of pictures and 20 hormone deficiency pictures and 19 hormone excess pictures. So you can always put here your mobile phone next to it. And then our partners, I want to thank all these partners I've thanked so much that help us to get this to their health professionals, this seminar. And these are the links you can link to. And with all the links, this is actually also on LinkedIn. This is on Facebook at the same time that we're doing all these things. So, and you have also a series of YouTube interviews that are really helpful for you to know more. And I really thank all the audience for being there. Here's the contact emails. I really thank Christophe. Christophe, really thank you for being there. We'll have to close now, but here you have really the links. If you want to get more information, if you want to go on the website with all training programs, other information, and we have a lot of physicians coming in office, a little bit less with COVID now, that train here locally. So that's also possible. Thank you for being there.
Thank you, Thierry. Thank you for everybody.
Thank you, Christophe. Thank you very much. Do well. Keep healthy. Bye-bye.
Bye-bye. Bye to everybody.